Look, the memo that I got indicated that this was supposed to be a sort of interactive thing. And so I haven't really prepared much in the way of didactic slides. I'm hoping to get you to do some of the work and ask you questions. It's built around a chap called Gordon, who's a man in his mid-60s, 65, which is an age that no longer seems as distant or as old as it used to, as I get closer to it myself, who's got long-standing exertional breathlessness and a pretty significant smoking history. 50-pack year history is a heroic amount of tobacco to have consumed. And he's got documented airways disease, as you can see there. Although I must say an FEV1 of 2.3 doesn't seem too terrible. So while I'd expect Gordon to be a bit breathless climbing 2 or 3 flights of stairs or running up Mount Eden, he ought to be all right wandering around on the flat. And in particular, he's recently given up smoking, which is a good thing, of course, and he hasn't had any obvious exacerbations of his airways disease and no hospital admissions over the last 4 years. So when he comes to see you, saying that he's got more breathless recently and he's waking up in the night breathless, then it suggests possibly that something else is going on apart from his long-standing lung disease. And the findings that are as listed there, he's normotensive, but he's clearly got an irregular heart rate with a ventricular rate of 110 beats per minute. He doesn't seem to be fluid overloaded, and your friendly Auckland Heart Group cardiologist has done an echo for you and tells you that there's global left ventricular impairment with an ejection fraction of around 30 to 35%. So firstly, so what do you think is the relevance of the global impairment in this history? Ted, I might have to ask you the question since you're up here with a microphone. Is it relevant that it's global and not regional? Yeah. That's right. I mean, I suppose it's the other way around, really. If it's not regional, then presumably he hasn't had a silent infarct. This is not, missed myocardial infarction. Anything in that history then that might explain the apparent deterioration? The AF, yeah, that's right. Interestingly, the ventricular rate, I mean, obviously 110 beats per minute at rest is quite fast, but as you'll see, a lot of the guidelines recommend that as the target heart rate to get down to with your initial treatment of AF. So I suppose the next question is, does he have heart failure? Ted, has this man got heart failure, do you think?
He's got global, nothing much.
Do you want to use the microphone?
Global means the whole ventricle not working so well. Are you talking about clinical heart failure? Well, I guess we've got that with the breathlessness, haven't we? So he does have, must have.
He must have, mustn't he? Yeah, I agree.
Yeah.
So, I mean, he's got orthopnea and paroxysmal nocturnal dyspnea. He's waking up in the night breathless, so those are cardinal symptoms of left heart failure. Presumably at night, even if he doesn't have frank pulmonary edema, he's got increased volume of blood and fluid in the lungs, which is usually put down to redistribution of fluid from the rest of the body when you're in the recumbent position. Do we need any other tests, do you think? We've got AF, we've seen that he doesn't seem to be obviously overloaded. His jugular venous pressure is normal, at least when he attends the surgery. We're happy to make a diagnosis of heart failure on those grounds? Sorry, that was a yes? Well, I'll go on to it's actually difficult without microphones, isn't it? I'm sorry about that. Look, this is from the European Society of Cardiology guidelines from a couple of years ago, dividing heart failure into those with reduced ejection fraction, which is an ejection fraction less than 40%, mid-range 40 to 49%, and then the group that I don't really understand, heart failure with preserved ejection fraction. So Gordon's got an ejection fraction of 30 to 35%, so he clearly falls into that first group, and according to the Europeans, we don't need any other tests. He's got symptoms, of heart failure. Doesn't seem to have any signs particularly. There was no mention of a gallop rhythm. Venous pressure, we said, was normal, but he's certainly got symptoms, and he's got a reduced ejection fraction. So that's enough to make a clinical diagnosis of heart failure. Now, somebody said that the probable unifying thing is the development of atrial fibrillation. Although it's hard to know, isn't it, whether atrial fibrillation is the chicken or the egg in this setting. More or less by definition, since you haven't seen Gordon with AF before, he's got first diagnosed AF as per this schema. But he may well have had it for quite some time. In fact, probably has had it for at least several days, if not a week or two. So probably he fits into the persistent AF group. And that's actually quite important because AF is not good for you. And it's associated with quite significant increase in cardiovascular morbidity and mortality, even though, we see it a lot. As I say, increased risk of death. It's quite a lot of significant increased risk of stroke. Stroke's very important. We worry about it a lot in atrial fibrillation. We've got a lot of trouble to try to prevent stroke in atrial fibrillation. It's important that people realise it's not the only, atrial fibrillation is not the only cause of stroke. But AF is also associated, possibly very importantly in Gordon's case, with left ventricular dysfunction and heart failure. I'm not too sure about the cognitive decline. I think, I'm a bit concerned about cognitive decline myself, and I'm still in sinus rhythm. So, but for Gordon anyway, it's an important part of what we talk about as rate-related cardiomyopathy. And so if we assume, and it is an assumption, that Gordon had normal left ventricular systolic function prior to the development of atrial fibrillation, he's been in AF for a while, then that by itself may be enough to explain his recent deterioration. And that rate-related aspect is really quite important and under-recognised, I think, lots of times. Just having, and I mean, rightly or wrongly, I tend to talk to people about the heart over-revving and getting fatigued. That's probably a bit simplistic, but nevertheless, if you have a persistently high heart rate for long enough, you will get systolic heart failure, left ventricular dilatation, and it's not good for you. So we've kind of answered that. These are his problems. He's breathless, he's got a high heart rate, and he's got left ventricular impairment. And sometimes it's a bit hard to differentiate the left ventricular dysfunction from the heart rate. And as I said, it's also hard to know sometimes which is chicken and which is egg. Picking up the heart rate, though, is quite important. And although, as I said, the brief was that Gordon had a ventricular rate of 110 beats per minute, it's important to know with atrial fibrillation that you're talking about the heart rate and not the pulse rate. At the hospital clinic these days, we have a healthcare assistant who checks all the patients as they come in and attaches them to a pulse oximeter and an automatic blood pressure machine and writes down the oxygen saturation, the pulse rate as given by the oximeter, and the blood pressure. But of course, the pulse rate and the heart rate may be totally different. In fact, usually are totally different in someone with atrial fibrillation. And you can significantly underestimate the heart rate if you just work off the radial pulse. I've put this slide in, which I've pinched off the internet. That's why I think it's got all those sort of spirals over it. But it shows you in green the ECG and in red the arterial pulse wave. And you can see that lots of those heartbeats or those QRS complexes don't generate a pulse. And obviously, if you have a very short RR interval, it may not produce enough stroke volume to open the aortic valve, or if it does, there's only a dribble gets out. So you may not feel anything at the wrist. And if you're just taking the pulse at the wrist, and you think, well, that's not too bad, it's heart rate of 80, pulse rate of 80, but it may actually be a heart rate of 120, which is quite a different thing. And the other thing which is quite useful to know in atrial fibrillation is what happens to the heart rate on exercise. Remember, Gordon's been breathless on exercise for a long time, but he's a lot more breathless now. And what I usually do if I see these people in the outpatient clinic or in the rooms is just get them to walk up a flight of stairs or walk around the area and come back. Just a trivial amount of exercise can increase the heart rate hugely. And that's another problem with atrial fibrillation and a problem why people get breathless, even if LV function seems to be normal. With relatively limited workloads, the heart rate is far faster than it needs to be. And if you have a very short RR interval, you don't have time for adequate ventricular filling between heartbeats. So, what are we going to do with Gordon? How are we going to manage this? Ted, what should we do?
Well, his breathlessness obviously is something that bothers him, and particularly orthopnea. So decongestion is certainly one of the primary things to do, and we're going to do that with some IV furosemide, very likely.
Do you think he needs IV furosemide? He's wandered in to see you and in your surgery or in an outpatient clinic.
Well, it's a little more difficult, but if he's orthopneic, you can probably use some oral furosemide. My feeling about this is, though, that it's bad, and he may well have intestinal congestion and not absorb the furosemide if administered orally. Now, if you use IV furosemide, of course, you don't need much. You don't want to smack in 200 milligrams of it or something, but you could give him 20 milligrams, and that would give him fairly quick relief. What would you think of that?
Perhaps a little more aggressive than I would be. I mean, certainly, I think decongestion is important. I mean, but he's euvolemic when you see him. That's what we were told. His venous pressure is normal. He's not grossly fluid overloaded. But he does get breathless when he lies down. So there's some redistribution of fluid, and you can soak up about 4 litres of fluid in the interstitial tissue before you actually start to see edema. But you would expect to see the venous pressure up a bit if he was significantly overloaded. But I agree, a little bit of furosemide might help him sleep more comfortably at night. But what about the heart rate?
Heart rate slowing is terribly important in the management of atrial fibrillation. And as I say, just because the resting value is not particularly high, if he does any exercise, I'll bet it rockets up. So certainly 110 is too fast for him in his present situation, so slowing it down would be good. Jim, would you choose to use something like beta blockers first, or would you have a preference for using diltiazem or...
Well, let's come back to the history, which I won't go all the way back through the slides, but remember that he had a diagnosis of chronic airways disease, an FEV1 of 2.5 or 2.4 or something, and no reversibility with bronchodilator aerosols, with beta-2 agonists. So do you think does anyone think that's an important part of the history? Does that influence the choice of medication? Well, I think you can use beta blockers. He doesn't have reversibility. It doesn't get any. His FEV1 or his peak flow rate doesn't change with Ventolin or with salbutamol or any of those things. So I think you could use beta blockers. The other important thing, which comes to Ted's question, is would you use a calcium channel blocker? Remember that his ejection fraction is 35 to 40%, wasn't it? Or 30 to 35%. It's quite reduced. And I remember Tim Sutton was saying this in the heart failure talk this morning, or at least the talk, post-infarction talk, that one of the most important medications in the treatment of heart failure is beta blockers. So I think that a beta blocker is the thing to do in this chap. As I've put on that slide, the risk to his prognosis, his likelihood of early death, of requiring hospital admission with further decompensation and so on, is a combination of things. It's LV impairment, which the beta blocker should help with by slowing the heart rate down and by producing some favourable degree of ventricular remodelling and protecting the ventricle from excessive levels of circulating catecholamines. And then, of course, there's the thromboembolic potential of his atrial fibrillation. He's 65, he's got impaired LV function, he gets a CHA2DS2-VASc score of 2, so normotensive, not diabetic. So, there's an indication to anticoagulate him as well.
Just on that other question of rate reduction, who here, and I'd like to hear Jim's comment on this, would use digoxin? Anybody? You're all too young, yeah.
Well, it wouldn't be unreasonable to use digoxin, but it's not first choice in this setting, I don't think. So there's a schema from the Europeans for managing heart failure. We could cardiovert Gordon. That would be a reasonable thing to do, except that we don't know how long he's been in atrial fibrillation. It might be several weeks. Hello. Screen's gone black. Oh, there we go. It might be several weeks, and so he could have a left atrial appendage stuffed full of thrombus. So if we were going to cardiovert him acutely, if he seemed that unwell, then he should be done with transesophageal echo guidance to ensure that he didn't have lots of clot in his left atrium. The value of cardioversion, though, in someone who's got why does that keep going blank? Oh, is it only my one that's going blank?
Yeah.
I'm sorry. I'm not imagining it. The value of trying to cardiovert someone, I think, is probably pretty limited. I mean, someone with an ejection fraction of 35% and a dilated left ventricle and so on, very unlikely to keep him in sinus rhythm for any length of time. And I think, really, unless he's acutely unwell, and Gordon's walked into the surgery, it's reasonable to start with a small dose of beta blocker, a little dose of furosemide, as you say, Ted, and try and crank the doses up. So those are the recommendations for the heart rate control and atrial fibrillation. Class 1, so you should do it in patients who have it. Gordon's on the second line there. Beta blockers plus or minus digoxin recommended if you have an ejection fraction less than 40%. So that's the recommendation there. Level of evidence B, so there's at least one randomised controlled trial to suggest that. Now, that's, yeah, okay, I've already said that. So if the ejection fraction were greater than 40%, then you could potentially use diltiazem or verapamil. I probably would use diltiazem, it's a bit simpler, and add digoxin as a second agent there as well. I need to just skip over the next slide or two because we have to get to, we'll skip over cardioversion. Stroke prevention we've talked about. So those are the sort of major points from the 2016 AF guidelines from the European Society of Cardiology. Look for underlying conditions. Alcohol, we don't know how much booze Gordon drinks, but that could be a big factor. Anticoagulate him according to the risk score. He's got a CHA2DS2-VASc score of 2, so he should be anticoagulated. Any modifiable bleeding risk factors like hypertension, well, he was normotensive. Alcohol intake, we probably all could do with reducing our alcohol intake, and controlling the ventricular rate. And those are the main things in that particular situation, I think. I'll skip over that. Modifiable risk factors talked about. So slow the heart rate and anticoagulate. That's what we need to do there. Now here's Gordon's twin brother, also called Gordon, but he actually has reversibility. So it's the same setting, really, but his FEV1 is also 2.3, but he's got more than 15% reversibility. So in the last couple of minutes, because I've rambled on a bit long, so what we do here, Ted, the important thing, as I said before, is that Gordon 1 didn't have reversibility, so you could treat him with a beta blocker quite easily. Gordon 2 does have reversibility, so beta blockade may make his airways disease worse, but he's got a dodgy ventricle, and so probably shouldn't be given calcium channel blockers because of their negative inotropism. So what are we going to do with this?
Can he have a beta blocker, this guy?
Well, he can. I mean, it's not an absolute contraindication, is it? You can certainly start with a small dose of beta blocker, see how he gets on. He's got his baseline peak flow rate is 300 mils per minute. That's an easy test to do in the rooms or in the surgery. So you can give him a little bit of beta blocker, bring him back next week, repeat his peak flow rate, ask him if he's wheezy and so on. So, you can do that, but it has to be very closely monitored. And the other thing that would be not totally unreasonable in this situation is your old friend digoxin.
What about amiodarone?
Yep. You could do amiodarone. The problem with amiodarone is Gordon's only 65. In the short term, amiodarone would be probably quite helpful. It would certainly slow the heart rate down, wouldn't have any negative inotropic effect, wouldn't make his airways disease any worse. But you have to have a long-term plan, because in the long term, amiodarone is associated with lots of very significant and unpleasant side effects.
Yeah.
So I'm down to my last 8 seconds according to the clock. I think that's almost my last slide.
I don't seem to have any questions here. Perhaps I could just ask you one or two. With regards to perhaps Gordon or perhaps or somebody else having a longer history of shortness of breath, and then he tells you that he was very breathless initially, and I know he's orthopneic now, but he seemed to improve. And it wasn't so bad. He got more ankle swelling then. So what's that mean? The fluid gone from his lungs to his chest? People, if he developed a raised JVP, would that make any, how would you understand that? The reason for this rather obtuse question, I suppose, is the fact that if you're in left ventricular failure first, and then you go into right ventricular failure, there can be a symptomatic improvement. Now, also with Gordon, the chest X-ray showed, what, lots of pulmonary edema?
No, we weren't privy to the chest X-ray, but I would expect it to show some upper low blood diversion, and some sort of perhaps a bit of hilar fluffiness.
If his chest X-ray was not showing any fluid, would that dissuade you from the diagnosis of heart failure?
Not really. We know that he wasn't flu. He was supposed to be euvolemic. That's what we were told. That his symptoms are on exertion, when probably if his resting ventricular rate's 110 beats per minute, on exertion he may have a heart rate of 160, 170, 180 beats a minute. That'll make, that's fast enough. And his recumbent symptoms were at night, when he was lying down. So if he's been up and about, and he's gone to have a chest X-ray, and his lungs don't look particularly wet, I don't think that. It's a clinical diagnosis, I guess.
Right. Yeah. So,
a question over there.
Got a question?
If the chest X-ray did show pulmonary edema,
No, it wouldn't be contraindicated. I suppose it makes it game, set and match for heart failure, doesn't it? But no, you need a bigger role for the diuretic to get rid of the fluid initially. But beta blockade is still a critically important part of the treatment of heart failure. You have to be cautious. You have to introduce it slowly. You need to see the patients every couple of weeks and increase the dose gradually. But it's actually life-saving in heart failure.
If his blood pressure was 80 systolic, what would you do, Jim?
Well, that is getting tricky. Digoxin may be helpful, but in fact, digoxin in heart failure is associated with an adverse prognosis, so it doesn't actually prolong your life, even if it helps a bit with symptoms. Amiodarone is probably the most helpful thing then, I would say.
Good. Well, any other outstanding questions? There's one.
Beta agonists have any implication on heart rate? Long-term, long-acting beta agonists, short-acting?
Beta agonists, you mean like? For his reversible airways disease you're talking about?
Well, just about, cardiac, have any implication?
Yeah, I mean, they do. Well, yes, if you have an overdose of salbutamol or any of the beta agonists, then you'll get a increased heart rate. I mean, remember, the selectivity of beta receptors it's not absolute. So the drugs we use for airways disease, for asthma and so on, are supposed to be beta 2 agonists with more effect on the airways and less effect on the heart, but they still have some effect on the heart.
What about the role of oxygen here? Has it got any role, Jim?
No.
With that lengthy explanation, I think we'll just clap Jim off the stage.